So let's look at the family planning consultation that's specifically focused on helping to explore a woman contraceptive options, or usually even just options in terms of how she wants to space her family. And there's actually a very good national contraceptional clinical guideline. What's interesting about this guideline is that it doesn't cover a lot of detail of the actual methods that you can find in the EML, but it's a 117-page document that actually looks at everything else. And there's a few components that they particularly highlight as being important when we are providing contraception. Obviously, quality of care, so ensuring that there's privacy and confidentiality, and very much to realize that contraception is very much a rights-based service provision. And worldwide, in terms of the world of sexual health and reproductive health, we are one of the most respectful in terms of the autonomy of the human being, in terms of contraception services. And there are many places in the world where there's still a lot of restrictions on how much rights you have over your own reproductive health. So ethics is a huge part of providing contraceptive care within South Africa, especially around autonomy and self-determination. And within that also to be very careful in terms of us being able to create services for a wide, diverse range of people. And I think the challenge with contraception is because when you talk about contraception, you're actually talking about sex, you're talking about bodies, you're talking about how people relate to sex and bodies. And we should not be making assumptions on what is best for somebody else, being respectful for what their particular requirements are. So very much client-centered, fits very nicely with a family medicine perspective. And within the clinical guidelines, there's also a huge emphasis that when we are providing contraceptive care, we obviously need to think of the wider range of sexual reproductive health services, including looking after HIV prevention and protection. Our contraception is when we're providing contraception, we are not actually treating an ill patient. So we do not call them patients, we call them clients, and we're actually providing a service. So it's like somebody coming to us to saying, I need this service, and we're providing them information, and they're going to decide what is going to be best for their life. In the ideal world, it'd be lovely to have the whole couple involved, and we should continue to encourage that. We make such an assumption that quite often it's the women coming in asking for contraception, that the men don't necessarily even want to be involved, that I don't think we often even invite them and say, listen, if you actually want to bring your partner with at the next visit so we can talk through all of this, please let's do that. So they have a little sort of summary of what should be happening within the contraception consultation. Greet, ask, tell, help, explain, return, reassure. I'll go through some of those briefly. I just wanted to start with greet, and that is in terms of very important to create a safe space. And when you are going to talk about contraception and you're going to talk about sex, you actually have to ask permission. And quite often we don't, we just sort of launch in. And just being able to say to somebody, listen, okay, great, let's have a conversation about this. I'm going to ask them personal questions. We're going to have to discuss some sexual stuff so I can make the best choice for you. Is that okay? Shows your respect for their autonomy and for their privacy in that scenario as well. One of the things that's becoming very important in our current political climate, if one can put it this way, and is a good way to help create safety, is to be very much aware of our LGBTQIA+ communities and our queer communities. And one of the ways to do that, a very simple way, it's a bit like code of showing that you are affirming, is asking them what pronouns they would like to use. And in the world of today, that's happened is by asking somebody's pronouns, it's now considered very woke, I believe, means a respect for the fact that people might identify differently than your perceptions of what them or what they think they are. So actually just asking that question highlights to people from not just trans people, but from people from the whole queer community that you are sensitive to diversity and that you are respectful of diversity. If we go through the ask part of it, this is the history taking. This is probably the biggest part of your contraceptive consultation. And because we are talking about contraception, we're talking about sex. So the CDC has what they call the 5 Ps. We have the WHO has now extended that to 6 Ps. And normally when you do a sexual health history, the pregnancy planning is the last P. But in this particular section, this will actually be your first P. And again, very important to not make assumptions. So when we ask about pregnancy, we want to know everything about their past history, obviously in terms of what contraception they've used in the past and whether they've had any pregnancies or miscarriages or TOPs, for example. and then very much what their future looks like. So what do they think is going to happen? What do they want to see happening? Do they want to have ever babies? And if so, when do they think they might want to have it? And really giving a way to explore their views on their reproduction. Very important, the next conversation is around partners. Again, to be able to, I think the challenge with our current way of taking histories is that we've got a very heteronormative approach to the consultation, which means there's a little bit of an assumption that everybody in front of you is straight. And we ask our questions in such a way that it's kind of awkward if you're not straight to sort of try and slip that into the conversation. So a lot of queer people are just not going to mention it because it's just not, there's just not an opening for it. In the CDC recommendations, they have these very open questions that you ask, which works quite well in a sort of maybe your global north. I find our patients just don't understand what we're asking. And so I've got a stock sentence that I always ask: do you have sex with men or women or both? And you need to be able to ask it in such a way that you're completely neutral and completely accepting of any answer. I actually find this quite a good opportunity to do a little bit of affirmation, because quite often you will get, especially your young men, I found that at my student clinic, and the guy said, no, oh God, no, I will never have sex with men. Oh, here, and you have this huge overreaction. And that's a very good place to also say, well, it's completely acceptable to have sex with men, and to also create a, that we are in a community and a society where we are embracing of diversity. And I think that's very healthy. And this particular guy, we end up having a very healthy conversation around sexuality. I'm not going to go through the details of all these questions, but I'm going to send you guys, we've got a nice sort of one-page summary on all the different questions. Same with practices, do not make assumptions. Again, be very clear, ask regardless whether it's male or female, whether the sex is genital, vaginal, anal, oral. And then obviously you want to talk about what they currently use to protect themselves from STDs. And this is about having a really good conversation about what's happening with condoms. And again, it's helpful to create safety here because people know they're supposed to wear condoms, but there's lots of reasons why people don't use condoms. And so to have a very safe conversation around what is your feeling around condoms, how often do you use it? Do you use it mostly? Do you use it sometimes? How do you negotiate condoms, etc. And then pleasure is the sixth part of the sexual health conversation. And we're actually very bad at asking people around their experiences of sex, but also here a little bit to consider your gender-based violence side of things, and being able to ask people, do you always have sex when you want to, is quite an important question, and whether to find out if there are any coercion or other things in the relationship which might be playing roles. So very important, as I've been emphasizing, is don't make any assumptions about your patient. In your history taking, very important to understand the comorbidities and any other medication your patients might be on, as there might be interactions. And then you want to make a risk assessment, especially if you've got a teenager that's asking about contraception. We need to make sure exactly who the partner is. Are they there completely voluntarily? Being aware of both their mental health and their substance abuse. And then also being aware of their risk for other potential illnesses. So this is a good time to ask them about pre-exposure prophylaxis, if they have ever used post-exposure prophylaxis, and that actually opens the conversation. So if you're going to have a conversation about contraception, you should also be having a conversation about pre-exposure prophylaxis, for example, and those two should go hand in hand. Your next step is now to explain to the patients all the options, and I think we're very bad at doing this. There's a little bit of a petagen preference in South Africa, and it's sort of, oh, I want contraception, and then we sort of whip out the injection, and we go, oh, you can have tablets, but you have to take them every day, and look, I have this lovely 3-monthly injection. But actually, we should be showing our parents, our patients, clients, all the different options. And in that national clinical guideline, it's on the Knowledge Hub, and I'll send it around as well. There's some lovely job aids on the last few pages that you can actually use with patients to help run them through all the different options. And quite often, patients are not even aware of some of the different options that might be available, or they might have various myths or things that they've heard, so they're not even considering that as an option. You obviously have to help your patient choose the best method. So it's not like a menu where you just give them the list and go, well, pick one. So in terms of what you have already now discovered about your patient, you might steer them into these are the 3 best options for you, and these are the pros and cons. And then once you've actually decided on which method they're going to use, it's very important to help them understand that. And sometimes we're not very good at, for example, talking about side effects, and we're not very good about talking about effectiveness. So people need to understand that almost no contraception method is 100% effective, and need to be able, how do we actually negotiate that? And then lastly, you'll obviously set your return dates and reassure them that they can come back at any time if need be. In terms of your physical examination, very important, we do not need to do a genital examination routinely on anybody who's about to start on contraception. Your examination has to be focused depending on what you have found in your history and in terms of what is relevant. Obviously, look for other opportunistic things. If they're over 30 years old and they haven't had a pap smear, you might want to arrange that. Very important, though, the only test you have to do before you start contraception is the pregnancy test, obviously. No need for bloods or any other fancy things. And your follow-up visits is actually relatively quick and relatively straightforward, where you basically check it, how it's going with that method, check compliance, check fertility plans. So remember, our needs for fertility and for children is going to change. So every single time somebody comes for a contraception visit, just double check what is happening at the moment in terms of their thoughts and ideas. So for example, if you've got somebody on Depo-Provera and they're saying to you, well, actually, I've just got married and we're thinking next year maybe you're falling pregnant, you need to start having a conversation about return to fertility, for example. So always have an ongoing conversation. Again, only examine as appropriate. So in terms of choosing then the best contraceptive method for our patient, there's a whole range of all the different